This is a brief talk about the Island trial. The Island trial was a pragmatic randomized trial that was published in the BMJ, as you see here, in 2020. And you can look it up and read the details anytime. I'll try to give you the highlights over the next few minutes that we spend together. First of all, as it relates to background and the question that we asked in this trial. Basically, Island tested the effects of a series of mailed educational reminders with or without the addition of phone calls from an automated interactive voice response system followed up by a trained lay health worker compared with usual care. And we wanted to know whether that would improve adherence to recommended secondary prevention treatments in patients who had had a heart attack. You see, in such patients, we know that if they stick with their recommended secondary prevention treatments, namely completing cardiac rehab and taking recommended medications, their likelihood of having another heart attack is drastically reduced. But we also know that there are major gaps in achieving just those guideline recommended treatments. So the trial design was 3 arms. You can see that we identified eligible patients and randomized them to usual care, or as you see, 2 different intervention arms, one being mailed educational reminders, the other being those same reminders sent via post along with phone calls. And those phone calls occurred in 2 steps. One was automated phone calls to assess whether people were on track. And if they were not, or any red flags were identified, then we had trained lay health workers call them to assess them. In doing so, we purposefully adapted the approach used in Ottawa to create and test a centralized model that could be scaled up to serve all heart attack patients across the province. We assessed outcomes 1 year post-heart attack to assess adherence to those evidence-based treatments for secondary prevention that we talked about, and we also assessed quality of life and health service utilization. And in addition to that, we embedded a process evaluation to understand how and why the interventions might work better for some than others, so we could learn and build the platform going forward. What we have on this slide describes the schedule for the repeated educational reminders that the eligible patients would get for the year following their heart attack if they were randomized just to the arm receiving printed educational materials only by mail, or the arm also receiving phone calls. Those time points were chosen very specifically to coincide when medication refills might be needed or appointments may be necessary to prompt those targeted behaviors. And the content also changed over time in accordance with what the people would be expected to need, or also with data that we collected. So if a person said they stopped their meds, the next call would prompt about whether in fact they restarted them. You can see here that we did publish the protocol, and you can look that up. And at the time, we described the extent of pragmatism of the trial using the Pressy tool. And you see there on the screen that it ranked fairly highly in our assessment using that. Certainly, the primary outcomes was less pragmatic, because the primary outcome was collected not with registry data like the secondary outcomes where we used ICS data, but the primary outcome was assessed by actually calling patients up and using validated self-report tools. So a little bit more about the setting and participants. We actually involved half of the cardiac centers across the province, purposefully trying to have a mix of community and academic sites with and without surgical backup. And we really focused in on patients who had had a heart attack who we could feel very confident that the recommended secondary prevention treatments would be applicable to. Then, and I want to emphasize this, what we did with allocation was that we used existing data sets to identify eligible patients. And we knew that we could do that using the existing cardiac registry. We could work with the centralized provincial registry to send the eligible patients back to each center. And then each participating center sent the information on to our trial coordinating center at the Population Health Research Institute, PHRI, who acted as their agent in carrying out the intervention immediately following the allocation that they would do. And so what they did was, once receiving information from each center, allocated to one of the 3 trial arms, and then carried out the trial from there. So when we look at the outcomes, as I mentioned, the co-primary outcomes were patient-reported. And so at 1 year, we would talk to the patients and use a validated approach to assess adherence to the generally recommended classes of cardiac drugs in the manner that you see here. They were tabulated. And then we also used a validated way to assess from patients' perspective whether they had completed cardiac rehab at 1 year. Then a whole host of secondary outcomes, that some of which were patient-reported, but many of them we collated from administrative data sets. Here, what we have is our complex study flow diagram. And you want to highlight that because of this sort of automated enrollment that I described in allocation, we were actually able to gain about 2,700 trial patients over the course of only 6 months or so into the trial. And so it's really important to highlight that we were able to do this in a way that didn't involve patient consent prior to allocation, in a sort of form of Zellen's design, which definitely carries some pros and cons, but it was really necessary in this instance to avoid selection bias in all of our interpretations. Keeping in mind that we wanted to test what would ultimately, ideally, become a provincial program. And in a provincial program, you don't ask permission for people, see if they're interested ahead of time. You would just roll it out. And so, to meet all sorts of, the ethical requirements, we had to provide opportunities for opt-out and certainly seek consent at the time when we did talk to people during outcome assessment. And the result of this approach was some loss to follow-up in each of the groups. And the greatest loss actually post-randomization was with the full intervention arm, perhaps because of all the opportunities for opt-out which we had to provide. And we dealt with that analytically using imputation methods as well as sensitivity analyses. And we actually didn't have any loss to follow-up for the admitted data analyses. And so you can see here a summary of the primary effects of the trial, that patient-reported cardiac rehab completion and patient-reported medication adherence. In summary, what we see is that for the full intervention arm that included the postal reminders as well as the phone calls, you have a significant odds ratio of 1.55 for cardiac rehab. But no differences across the arms for medication adherence. And then, as I said, we did have admin data for some of our secondary outcomes. This is the survival curve for the trial, and you see here in the full intervention arm, we had just approaching statistically significant difference in survival for that arm, which is pretty remarkable, given that we didn't plan or power, specifically for that. Circling back to the, unusual approach to ethics that we took, I want to emphasize that there are a standard approach where waiver of informed consent is appropriate, and we had to make that argument to each of the ethics boards that were involved. And in fact, we were the first academic project to go through Clinical Trials Ontario, and certainly the first to go through with this kind of alteration to the normal approach to consent. These arguments for when you can deviate from the normal approach to consent are laid out specifically in the TCPS, And we followed them and built our arguments accordingly, and we're successful in moving the trial forward in every site that we tried to. A few words about the intervention design, because this trial really involved an amalgamation of data science and using registry data and so on, as well as behavioral science, thinking about our targeted behaviors as being something where we needed psychology and user-centered design to help us with. And so we did involve evidence from a pilot study, evidence from a series of mixed methods approaches, and involved a multidisciplinary team of clinicians and scientists and a design firm to help us in an iterative user-centered design process. We created, as you see here, customized envelopes to make sure that people wouldn't confuse our postal reminders for like fundraising materials. We tried to make sure all the images were accessible and relatable. We included content that prompted them to think about their family and friends, to think about how they might stick with and achieve their goals, to make plans for when things might go wrong, to speak with their doctor, to enable that referral, if necessary, to cardiac rehab if that ball had been dropped, and really tried to think through all the steps that might be necessary. The next thing that I think is quite helpful to talk about is the data flow, because definitely beyond the interventions, this is our key innovation, which was leveraging the existing data holdings within the sort of appropriate approaches to the privacy legislation to take a proactive approach to thinking about the circle of care and using data to support patients. And basically, CCN stands for Cardiac Care Network, which is now called Core Health, which is now part of Ontario Health. Regardless, it holds patient data registry for cardiac patients. It prepared a file for each hospital's own data. And the hospital then had an agreement to work with our trial coordinating center as with PHRI, the coordinating center, as the hospital's agent to reach out to those patients on behalf of the patient's own cardiology team, which then moved into the intervention phase. And so I think, making the argument that there's an opportunity to use our data more proactively really is one of the exciting aspects of this trial. And then just as before we wrap up, some really necessary points of emphasis that I had the opportunity to lead this in collaboration with J.D. Schwam, who's a cardiologist in Hamilton at PHRI, and it really was an amazing partnership that included also a whole list of co-investigators that are named on the screen here. We had statisticians, multiple statisticians and program managers, and amazing research coordinators at PHRI who are named here as well. And really, it was a real organizational feat to pull this off and do it as quickly as we did. And in order to enable that, we did have funding from the Ministry of Health. We did have data support from Core Health. And of course, as I mentioned, the design group at Pivot that we worked with were really, really essential, as were the cardiologist site leads at each of the partnering sites. And so, with that in mind, just want to thank those who were involved and thank you for listening into this.